Good evening, everyone. We just want to welcome you this beautiful, gorgeous spring evening that we have today to our Tuesdays with the Doctor. This evening, we have a special guest with us to talk to us about women's health. And we hope this will be helpful to you or to a woman that you know. Our speaker is going to give us a presentation first, and then afterwards we will take questions from the audience. And we know you're joining via Zoom and via Facebook, and we're happy to have you with us. And we would like you to post your questions if you're in Facebook, to post your questions in Facebook, and we will answer those. And you can also post your questions in the chat on Zoom, and we will answer those as well. If you have questions that you would like to ask anonymously, please just send them in the chat to myself, Annette Barnes, and we will make sure, I will make sure that our speaker gets them and will answer them for you. And then you can ask those questions anonymously. So I would like to introduce our speaker this evening. Her name is Pam Lawlor, and she started in women's health in 1981 as a medical assistant. Beginning in 1989, she worked as a nurse, first at St. Peter's Hospital on a medical surgical floor, and after a year returned to women's health. She graduated with her nurse practitioner certificate from the University of Pennsylvania in conjunction with Planned Parenthood's Women's Health Nurse Practitioner Program. And she has been a nurse practitioner for 25 years, working most of that time for Planned Parenthood. She also worked for Franklin County Health Department in Lewisburg, North Carolina, in the Family Planning Clinic. And she currently works for a gynecology practice in Raleigh, North Carolina. And so now I would like to turn it over to Pam Lawlor to give us our presentation tonight. Welcome.
Great, thank you very much. It's a pleasure to be here. I thank the Joy of Troy Church for inviting me, and I hope to see some new faces and some old faces on the talk tonight. So bear with me while I get you all into my view. And there we go. All right. So we're going to spend a few minutes talking about the women's health exam. I hope that you have some humorous times, as well as get to learn some new things about the exam and get some educational information as well. My first question for you all, and maybe 2 or 3 people could just take a minute and answer this question, is at what age should you start having a women's health exam? Just shout it out. Nobody knows. Nobody wants to guess?
They can guess now. You can unmute yourselves.
Oh, okay.
All right. Probably when
40.
you start your period.
There you go. No, all right. Around the time to start your period. Okay. Anyone else?
I will say 18.
Okay. 18. Anyone else?
I'd say 25.
You're all wrong.
Of course we are.
But we'll come back to that. And then the next question I have for you all is, when you think of a woman's health exam, when you make your appointment to go in to see your gynecologist, and what do you expect from that exam? What's included in it in your mind?
An
Pap smear.
internal exam.
Pap smear. What was the other?
I just said an internal exam.
Internal exam. Okay. All right.
Breast exam.
Okay. Okay.
Height, weight, general physical stuff.
Okay.
Compassion from the doctor.
Okay.
There you go. That's a good one.
When I was younger, I anticipated pain.
Okay. A lot of my young women do. A lot of my young women do. All right. Well, let's talk about it. The topic is the what, when, and whys of the women's exam. So the first thing is, what is it? And you're right about some of it. You know, the basic reason to come in for a well woman exam, particularly if you're on any prescription medications that your gynecologist is prescribing for you, is to review and update your personal history. See if there's any new medical diagnoses that need to be addressed or reviewed. You know, check on your social status. Are you smoking? You know, do you have occasional alcohol? Are you using any type of drugs? Are you sexually active? What are you using for birth control? And some other issues like abuse issues, if there's been abuse in the past and things along those lines. They generally do include your weight, your blood pressure, and your last menstrual period, assuming you're still having periods. Height is more essential in women as they get older. It's not quite so urgent to get the height on a teenager or a 20-something, but you want to address weight or height loss as women get older. It can be a sign of osteoporosis or osteopenia. The physical exam can be a full exam, or it can be a limited exam, and we'll talk a little bit more about that as we delve into this. When should you start? I said you were all wrong. You know, years ago, I've been doing this long enough that it was as soon as a young woman became sexually active, they came into the office and they got a pap smear. And of course they got STD screening and everything else that they needed. They did a whole exam on them. They backed off on that probably starting about 10 years ago. The recommendation, if a young woman is not sexually active and has no medical or health problems, is to see the gynecologist when she turns 20. At 20, the recommendation is to have your first breast exam. We don't start doing pap smears on young women anymore until they turn 21. And the reason for that is the pap smear abnormalities that we would find in young women tend to go away over time. And many young women were being, should we say, over-treated, over-tested, over-scanned for things that if you just monitored them, they would just go away. So the well women exam, quite honestly, the recommendation is to start at 20. Now, that does not mean to say that you should not bring your young ladies in sooner. They certainly can and should be seen sooner if they're having some medical problems. The next question, why should you have your exam? We sort of covered a little bit that already. It's a good health maintenance, and a lot of women use their gynecologist as their primary care provider if they're not having any primary care issues, if they don't have diabetes and they don't have hypertension, if they don't have other medical issues that need to be addressed by a primary care provider. Their gynecologist is their primary care provider. They come for their regular checkups. They come to get prescriptions refilled. They come to discuss their concerns, and many of them are related to women's health, but we do have patients who come in and ask about a rash that they might have or a skin lesion that they might see. Should they go see a dermatologist, or is this something that, you know, is going to just go away? So particularly in the younger population, most gynecologists will act in the role of a primary care provider as well. So when we get into the exam, ACOG, which is the American College of Obstetricians and Gynecologists, recommends starting GYN exams between 13 and 15. Other groups recommend 13 to 19. And the big discrepancy in that 13 to 15 or 19 comes because there are some young women who are 13, 14, 15 years old who are sexually active. And if they are sexually active, they definitely need to be seen, but they may not be comfortable having their pediatrician do an exam, or even telling their pediatricians that they're sexually active because they don't want their mother or their father to know. Some young ladies between those ages also have very painful periods. They're not managed well with ibuprofen or Motrin or Pamprin. Many of you that are my age probably remember Pamprin very, very well. Their pediatricians may have been trying to treat them, but they've been unsuccessful. Some young women haven't had their periods. The average age for a young woman to get their period is right around 12 or 13 years of age. Some a little bit younger, some a little bit older, but that's the average age. So sometimes they'll come to maybe have some blood work, again, that their pediatrician just is unfamiliar with what should be ordered, or they've done all the workup and they can't find any reason for the young lady to not have periods. So they send them to our office or to a gynecologist's office for further evaluation. There are some other things like, abnormal vaginal discharges. In rare cases, the hymen, which is the little skin tag that goes across the vagina in young women, has not stretched, it hasn't opened. And so the young woman might be getting periods, but she's not able to express that period from the vagina. The blood just kind of builds up, which can lead to pain and discomfort. Most patients will, if you will, age out of pediatric care somewhere between the ages of 19 and 20. So sometimes they're just moving from childhood care into young adult care. And they just want to be seen and checked to make sure that everything is okay. The next group that we want to talk about is the dreaded exam. I titled it because most of my young ladies who come in around 18 or 19 years old come in and they're terrified and nervous about having their exams. So in this age group, remember I said we're still not doing essentially a full exam on them. Yes, they come in, you look at their medical history, you look at their social history, as I said, you check their surgical histories to see if they've had any surgeries. You want to look at their immunization records. Have they had their measles, mumps, and rubella, their tetanus shots, their HPV and their flu vaccines? You want to talk to them about whatever specific concerns they might have. As I said, what are their periods like? Are they regular? Are they heavy? Are they light? Are they really crampy? If they're sexually active, what are they using for birth control? Many times they'll come in just using condoms. Sometimes they have talked with their pediatricians and they are already on a birth control method. They may or may not be satisfied with it. And you want to make a follow-up plan with them. The thing that I find most beneficial and most helpful with young women in this age group is just talk to them. Just talk to them. Don't sit up on a high chair so that you're looking down at them. Sit down at their level. Explain things to them. The first thing I usually tell the young ladies in this age group is the only exam that I'm going to do today is to listen to your heart and lungs unless you're having a problem. And that is pretty much what is indicated in young ladies this age. Listen to their heart and lungs. As far as testing and screening, if they're sexually active, nowadays you can leave a urine sample and we can do testing for chlamydia and gonorrhea and other infections right off the urine. So there's no need anymore to put that speculum in and terrorize young ladies. And then the recommendation is for them to come back once a year unless they're having some problems. And in that age group, honestly, if they're not having any medical issues or GYN issues, they can wait until they turn 21 or 20, either one. All the things that we're going to mention and talk about tonight are just guidelines. They're not set in stone. One of the things you learn in the medical profession is not everybody fits into the guidelines and recommendations for a variety of reasons. And so you should work particularly with your younger patients when you're talking to them about those things. Next age group, 20 to 29-year-olds. So as I said earlier, 20-year-olds do need a breast exam. The recommendation is to start a breast exam at 20. Recommendations are usually every 1 to 2 years, although most of the practices I've worked in and most of the patients that I've seen will get a breast exam done on an annual basis. But in that age group, every 1 to 2 years, unless there's a family history of breast cancer, unless the patient is having breast pain or has had a breast lump or a breast mass. They don't generally need those done every year. Some of the things you're going to want to ask them is, are they sexually active or have they never been sexually active? That's going to come into play when we talk about cervical cancer screening. You talk about their contraceptive needs if they are pregnant or are, excuse me, if they are sexually active. And I know Rachel has some slides for that, but I want to hold off until we get down a little bit lower into further into the discussion on that. And then again, you know, the clinical breast exam. So the cancer screening, several people gave an answer about when to start the exam. Does anybody have a guess as to when you should do your first pap smear, which is the screening test for cervical cancer? You're gonna have to unmute yourselves again if you want to answer.
16?
I'm sorry?
16?
16, okay. Anybody else got a guess? Well, no. 16 is way too young to be doing a pap smear on a young lady. First pap smear is recommended at age 21. Again, that's a recommendation. If I have a 21 or a 22 or a 23 or a 24 or a 25-year-old who comes in and says, I've never had sex, I've never been sexually active, we don't have to do a pap smear on that patient if she doesn't want to. Pap smears, as I said, are the screening test for cervical cancer. The #1 cause for cervical cancer is the HPV virus or the human papillomavirus. The human papillomavirus is a sexually transmitted virus. So if a young lady has never had intercourse, her risk for cervical cancer drops down to like 1%, 1 to 2% of the population. So if she is afraid of the exam, not ready to have the exam, you can talk to her. You can say, okay, we won't do it this year, but let me at least look on the outside and make sure everything looks normal. So we lay the patient back, she puts her feet up in the stirrups, and basically you just say, you're going to feel me touching you on the inside of your leg. You're going to feel me touching you on the outside of the labia. And I'm just going to look and see that the vulva and everything looks normal. I'm going to look at your hymen to make sure that it is not still intact. And that's all we're going to do for the day. We're not going to do anything else. And she's on her way. And you have probably made her feel so much more better, not just about the exam, but about her ability to negotiate with her healthcare provider when she has fears and worries about something. If they need contraception, you need to have a discussion with them about that. And you need to ask them about their HPV vaccines if they have not completed it. Rachel, can you put up the poster for the contraceptive options at this point? So contraception, you know, the most important thing in my mind for contraception is that it works. Can anybody tell me what the only 100% method of birth control is? This should be an easy one.
Abstinence.
Abstinence, yes. It is the only 100% method of birth control that exists. There are other options that are very, very reliable. And on that top row, you'll see the implant, which is called Nexplanon. That rod is a little rod that is impregnated with progestin hormones. It is good for about 3 years. The next is the hormonal IUDs. And there are several of those. We'll come to those in a couple of minutes. They are good anywhere from, actually, this is an older birth control poster. There is one IUD on the market that is good for 6 years, one hormonal IUD that is actually good for 6 years. And then you have the copper IUD, which has been out for many, many, many years. When I first started practicing, the copper IUD was only good for 8 years, and then it went up to 10 years, and now it's approved in the United States for up to 12 years. In Europe, it is actually used for 14 years, but in this country, it's only approved for up to 12 years. Non-hormonal, and then the last one is sterilization, whether it's men or women. All of those contraceptive methods are 99.8% 8 or 9% effective, depending upon the studies and the research that you read. So the biggest complaint, Nexplanon, as I said, it's a little rod. It goes underneath the skin in the non-dominant arm. It's a minor office procedure. The patients, especially the young patients, like to think of it as surgery, but it's really not. You just wash the arm, apply a little local anesthetic. And like when you get your ears pierced, you put a little needle under the skin and push the button, and it shoots it in underneath the skin. Leaves a small 2 or 3 millimeter scar. Most common complaint with it and the hormonal IUDs are irregular bleeding. So when you're counseling patients, or if you're thinking about getting any of those 2 hormonal options, you have to be prepared to deal with some irregular bleeding and spotting. Some patients don't get any bleeding with those, but more often than not, patients are going to have some kind of irregular bleeding. The 3-4 hormonal IUDs, Rachel, I know we're a little out of order, but could you go through that to that screen that has the IUDs on it? These are the 4 hormonal IUDs that are on the market. Liletta is the one that is good for 6 years. Mirena and Kylena are both good for 5 years. And the Skyla is good for 3 years. You'll see on that grid, it tells you how much hormones are in each one of the IUDs, approximately how big they are and how long they will last for. Skyla, you usually will get a regular period because it is a low dose hormone. Kylena, more patients do get regular periods with Kylena than with Mirena or the Liletta. They are a very effective method of birth control, and they're very good for people who cannot remember to take birth control pills. Can we go back to that other slide now? So the next row are birth control options that are relatively effective. You'll see the IUDs, and we call those LARCs, long-acting reversible contraceptions, although sterilization should not be considered reversible. You'll see that less than 1 out of 100 women get pregnant a year using those methods. With the pill, the patch, the ring, and the depot shot, that average drops down to somewhere between 6 and 9 women getting pregnant in a year. And that's because they're more user dependent. So if you miss a pill, if you don't take your pills regularly, if you forget to change your patch or your ring, or you're late coming in for your depot shot, all of those things can interfere with the effectiveness of the birth control. And then the last one are the ones that don't work quite so well. I love the picture of the cork. I had to look really closely to see what are they doing with, I don't understand what that means. That is for withdrawal. I do have a lot of patients who use withdrawal, and I tell them it is better than nothing, but it is not that great. It's somewhere in the neighborhood of about 15% effective. The calendar, which is what a lot of people who don't want to take hormones will use. We used to call it the rhythm method, for those of you, again, who are old like I am. And then you have the condoms. And there are 2 types of condoms. There is the male condom, which people are very, very familiar with. There are latex and non-latex condoms for those that are sensitive to latex. And then there is a female condom. A female condom actually goes into the vagina, and then the penis is inserted into the latex condom. Again, really not that effective for birth control, but when used in combination with any of the above mentioned methods, they probably give you close to 100% protection as well. And let's see here, I lost Rachel put me in full mode, so I got to get out of where I am. There we are. All right. So we talked about their management plans, their physical exams, and their contraceptive options. I put the HPV vaccine in here, but I am going to talk to you about vaccines towards the end, just so that they're all clumped together and we don't have to keep going back and forth on them, because the vaccine recommendations are a little odd, to say the least. So 30 to 39-year-old women, How often, well, how often do you think you need to have a pap smear? That's my next question. What's your thoughts?
You can unmute and answer or answer in the chat.
Thank you, Miss Rachel.
Every year.
Okay, every year. Anyone else? Well, this too is going to depend on your age. In the group between the ages of 21 and 29, if their pap smears are normal, the recommendation is to have a pap every 2 years. I still am a little old school. I generally do them every other year. But in 2020, the beginning of 2020, right around the time COVID came out, the recommendations did change to every 2 years in that age group. And the reason for that is twofold once again. The HPV virus, if it is present in a young woman and not expressed on a pap smear, the risk for cervical cancer is very low. What I'm going to talk about right now with the frequencies is really just for women who are having normal pap smears. No HPV, no infections, nothing else. So routine paps for women 21 to 25 are every 2 years. Women in above 30, irregardless of how old you get beyond 30, the recommendations are still a pap smear. Again, in my practice, we do every 3 years. The guidelines from the American Society for Colposcopists and Cytopathologists is every 5 years. Most providers that I know and I work with are a little uncomfortable doing 5 years, even with normal PAPs, but they are relatively comfortable with doing them every 3 years. There are 2 types of pap smears you can do. Women under the age of 30, you do a pap smear. If the cells are normal, they don't do anything else. The lab just stops right there. Her pap is normal and we're done. If she has an abnormal pap smear, let's say she has, they classify it as ascus, which is sort of a junk term. Ascus means atypical squamous cells of undetermined significance. Atypical cells means the cells are not normal. Squamous cells are skin cells that are present on the cervix. And undetermined significance just means they don't know why they're there. So what they do with those PAPs is they look for HPV virus. If the HPV virus is negative, it's considered a normal PAP because other things can cause those atypical changes. Patient comes in, just finished a period and had a tampon in the day before she came in for her appointment. Or they had intercourse the day before that, or maybe they had a mild yeast infection, or it could be just normal sloughing off of the cells and new cells growing in. So an atypical pap smear without HPV is considered a normal pap smear, and that young patient would have another pap in 2 years. If she has a pap smear that is considered low grade or mild changes, that is pretty much 100% of the time associated with the HPV virus. And the recommendation for a young lady under the age of 25 would be just another pap again, routine in a year, excuse me, just to see if that HPV virus cleared, which in women under 30, it will clear in usually 1 to 2 years. Patients who are over 25 that have a low grade or mild pap smear generally are referred for colposcopy, and we'll talk a little bit more about that down the road. Women in the age group of 30 and above, there is no, oh, let's see what the pap smear shows, and if it's not normal, we'll do HPV. All women over the age of 30, when they have their pap smears, assuming they're having them done every 3 to 5 years, should have HPV testing done with their pap smear. If their pap smear is normal and their HPV testing is normal, their risk for cervical cancer.
Pam, you're muted. That's my fault by accident. You have to unmute. You have to unmute. No one touch Pam's buttons. Let her unmute herself.
Thank you.
Perfect.
Can you hear me now?
Yes,
Okay.
I
I could,
apologize.
it's not a problem. I couldn't find my name, so I couldn't unmute myself by looking for my name. Sorry. So I don't know where I left off or what you heard last, but if somebody could just give me a shout, what the last thing was that you heard?
Just back up a little bit and
Okay, I was just going to say, if nobody remembers, I'll just go back. So women over the age of 30 should always have what we call a combination pap. It looks for cells on the pap smear and it looks for HPV virus. If both of those are negative, the recommendation is a pap smear every 3 to 5 years, depending upon your comfort level. For patients who are uncomfortable in that age group having a pap every 3 years, you can have just a regular pap smear with no HPV testing. As long as your cells are normal, you can continue to have paps every year, because if they're not normal, they're going to do HPV testing, assuming that it is ordered that way. Clinical breast exam is recommended every year. You should always, again, talk to the patients. Are they sexually active? Have they had a partner change? Do they need any STD testing? Do they have contraceptive needs? Are they seeking pregnancy? I didn't think about that actually until just now. Are they seeking pregnancy? If they are seeking pregnancy, are they taking a multivitamin? Are they up to date on their measles, mumps, and rubella shots? How long have they been seeking pregnancy? That type of thing. Women who get to that middle age, 40 to 55 years of age, their contraceptive needs tend to change. Some patients have had tubal, some patients have had the IUDs put in. Some patients will start noticing irregular periods. They might go, instead of every 4 weeks, every 6 weeks with a period. They might have a heavy period one month, they might have a light period the next month. When you get close to 50, even late 40s, you might start having some hormonal changes. So you might be experiencing the occasional hot flash or night sweat or flushes during the day. Screening recommendations are pretty much the same for the pap smear. Mammograms start at age 40 in most practices. And I say most practices because depending upon whether you look at ACOG, the American College of Gynecologists and Obstetrician, or the American Cancer Society, or the United States Preventative Servicing Task Force, they all will give you a different recommendation. Some start mammograms at 35 with their baseline and recommend another one at 40. Some don't recommend them until you turn 50. In most of the practices I've worked in, we recommend them at 40, and we do recommend them every year. And we do recommend a 3D mammogram for patients. It is a little bit more detailed, and it's able to pick up smaller and more discrete masses than the 2D mammograms that some of our older people here on this platform might be familiar with. Most insurance companies at this point are paying for 3D mammograms as well. Other screening recommendations, the changes for colonoscopy came out earlier this year. For African-American women and men, the recommendation for colonoscopy is to start at age 40. And for Caucasians and Asian, it is to start at 45. And the rationale behind that is that they were finding more cancers in younger people. So they decided to lower the ages on that. And then we get into the menopausal years between 56 and 65. And I should mention that most women enter menopause at around age 51. Medical diagnosis of menopause is no periods for 1 whole year. And that's assuming somebody doesn't have one of those progestin IUDs that we talked about in place. And by 55, most women have completed their menopausal years and they will have not had a period in over a year. So when you get into that age group, what are their menopausal needs? So pap smears. Have they had an abnormal pap in the last 5 years? Have they had a hysterectomy? Have they ever had HPV in the past? So if their pap smears have been normal for the last 5 years, you continue with your paps every 3 to 5 years. The new recommendations are no more paps after the age of 65, simply because the risk of cervical cancer in women in that age group is extremely low. Life expectancy is roughly 20 years. Average age of life expectancy for a woman in the United States is about 84. And the vast majority of cervical cancers caused by the HPV virus take about 20 years to grow, to start. So stopping them at 65, if a woman got cervical cancer or has HPV at that point, especially one of the viruses that might cause cervical cancer, by the time that they have the diagnosis of it, the question will be, are you going to do more harm than good in treating them? Now, that is not to say you cannot have a pap smear after the age of 65. That is just a recommendation. And I do have a large majority of my women who still want to have their pap smears. So again, it's just a recommendation. I also have some women that can't wait till they turn 65 because they don't want the dreaded pap smear anymore. It's a conversation you need to have with your provider. If you've had a hysterectomy, if your hysterectomy was done for non-cancerous reasons, so for fibroids, for heavy bleeding, for endometriosis, and your cervix has been removed when you had your hysterectomy, you no longer need pap smears. You can't get cervical cancer if you do not have a cervix. Some women do not have their cervix removed when they have a hysterectomy. They need to continue to be screened under the guidelines. Mammogram, continue your mammograms. There's a couple of articles that have said stop doing your mammograms at around 75. Some say 65. To me, this is, again, a personal preference. And the rationale behind it is if a woman develops breast cancer at 75, the treatment is probably going to be harder on her than the cancer, particularly in the slow growing cancers that women can develop. And then a DEXA scan. If your DEXA scan is normal, you should have a DEXA scan about every 5 to 10 years. And that just looks at the density of your bones, usually in your hips, your ankles, sometimes in your elbows. There are reasons for doing DEXA scans earlier, long-term steroid use in women. Some providers will do it for long-term use of Depo-Provera, because Depo-Provera in the studies did show that there was some bone loss in people who use Depo for long periods of time. So sometimes we will do a DEXA scan in somebody who might be 40 or 45 if they've been on their Depo shot for 20 years or so. And then what are their postmenopausal concerns? The number one postmenopausal concern is, I was going to ask you guys, but I'll just tell you, it's pain with intercourse, it's vaginal dryness, and it's lack of desire, sexual desire. Those are probably the two most common reasons that women will come into the office with that. And there are some treatment options. Some are hormonal, some are not. Women can do vaginal estrogen creams without getting the systemic effect that oral medications or patches can cause. The oral medications and the patches are used usually for women who have hot flashes, night sweats. It interrupts their sleep. They can't function during the day. They're tired all the time because they're not sleeping at night, where the vaginal preparations really are localized. So they're absorbed into the vagina. They are good for women who are having pain with intercourse or vaginal dryness, even if they're not having intercourse. Vaginal premorins, vaginal estrogens can also help with urinary symptoms. Sometimes incontinence is caused by the lack of the fullness of the tissue around the urethra. Adding some estrogens to that will plump that up enough that the urinary issues are either less bothersome, and in some cases, if they're mild to begin with, they'll just go away. The 66 to 86-year-old women still have some menopausal, postmenopausal concerns. I think the average woman that I see in my current practice is probably around the age of 80. We do have some that are a little bit older, but they're probably around age 80. Most of them are not still sexually active, but many of my 60 and 70-year-olds are still active. So again, are you having vaginal dryness? Are you having any other concerns? If there is a lack of sexual desire, there are medications that can be used by women. Some are taken on a regular basis. Some are just used around the time that you're going to have intercourse. I will tell you, I'm not that familiar with all of those because I see a generally much younger population in my practice, and I don't prescribe them that often. So if I have a patient who comes in and is interested in doing things like Vyleesi and other medications, I usually refer them to one of my other providers in the office to manage those things. So we're going to talk about the contraceptive methods. We talked a little bit about the most effective to the least effective. Can any of you tell me the one method, and many of you may not be familiar with this, but can you tell me one method that I did not mention that at one time was very, very popular as a non-hormonal method of birth control?
Please
A
put your answers in the chat.
diaphragm.
Oh, let's start with, I don't know who LGL84VL is, but let's start with you.
Lois Griffin, and it's the diaphragm.
Okay, well, don't need to go any further because Lois is right.
I wonder why.
The diaphragm, I can remember probably 20 years ago, was a very common method of birth control that patients looking for non-hormonal birth control but didn't want to do the copper IUD and didn't trust condoms would come in and ask for. It was about 80% effective, 80 to 85% effective, but they are next to impossible to find anymore. The last 2 to 3 patients that I've had that came in and wanted them, I gave them a paper script and they called multiple pharmacies and were told they couldn't get them anymore. The pharmacies just couldn't order them anymore. I don't know if it has something to do with latex allergies because they were made out, well, some of them were silicone, but some of them were latex. I don't know if they just dropped off to in use so much that the company has just stopped making them, at least in the United States. And I have to clarify that because there are a lot of other countries who use methods that we don't use here in this country or we don't have available to us in this country. But the diaphragm is one that is just not available anymore.
Pam, they started breaking. That's why they ended up getting rid of them.
Okay. So we talked a little bit about least effective to most effective, hormonal versus non-hormonal. Hormonal birth control is always going to be more effective than non-hormonal, with the exception of the tubal ligation and the Paragard IUD. The IUDs that we talked about, the progestin-only IUDs, I just want to touch quickly on the side effects of all of them, and I can answer questions that you have at the end of the talk. For hormonal IUDs, as I said, the most common complaint is irregular bleeding. That can be anywhere from, I don't get a period for 3 months, I spot for 2 days, I don't get a period for a month, I bleed for 5 days, to I don't get a period at all. My patients, I always warn my patients because they all come in saying, I want something that's going to stop my period. And I tell them 10 to 14% of women don't get periods on those methods of contraception, the Nexplanon, the IUDs, and the Depo. For cycle control, the pill, the patch, and the ring are your best options because basically what those do is they take over the functioning of your ovaries and they manage when you're going to bleed. And we call it periods, but it is actually a withdrawal bleed. You're bleeding because we are withdrawing the hormones that were preventing you from bleeding. They are also very good for women who have severe cramping, for patients who have heavy bleeding, and the IUDs are also very helpful for that. But for the woman who likes to have a regular period, combined hormonal contraception is the best route for them. The pills, I'm guessing most of you are probably familiar with. You take a birth control pill every day. Years ago, it was 7 days or 21 days on, 7 days off. Now they have pills that are 24 days of active pills and only 4 days of placebo pills. So we just need to, you need to counsel, or you need to talk to your provider. What kind of pill am I getting? What pills can I not worry about taking? And what pills do I have to make sure that I take every single day? Bleeding problems, bleeding issues. Women bleed all the time. In case you guys didn't know that, women bleed all the time. Premenopause, pre-period, before you start your periods, you might have an occasional spot here, a spot there. You may get regular periods once your periods start. Most young people, as I said, start a period somewhere around 11 or 12, up to 13. I've had patients as young as 9. And their periods are usually very irregular to begin with. Can take up to 2 years or more for a young woman's cycle to become regular. Regular menstrual cycle is not every 28 days. It is anywhere from every 23 to 35 days. So roughly every 3 to 7 weeks, 7 weeks. Other bleeding, perimenopausal and postmenopausal. And what ones should we worry about? So the irregular bleeding that happens in the young woman who hasn't had a period for at least 2 years is just, it's normal. It's annoying, it's bothersome. It may make the young people crazy, but it is what it is. It's not a pathological thing. It's not something that is going to harm you. Perimenopausal bleeding is annoying, much like those young ladies who are just getting their periods. When you are perimenopausal, you can have those same kind of symptoms. You can miss periods for several months in a row, and then all of a sudden start having regular periods. The most depressing woman who comes into my office is the woman who says, I haven't had a period for 10 months and this morning I woke up with my period. That can happen. Postmenopausal bleeding is not normal. If you have gone more than a year without a period and then you have bleeding, it may be a polyp, it may be residual fibroid, it may be nothing, but it is considered abnormal until we can find out that it's not abnormal. Postmenopausal bleeding can be a precursor to endometrial cancer. So if you have that, you really need to see your healthcare provider and let them do an ultrasound or an exam or whatever seems pertinent based upon your other symptoms. So common causes, premenstrual, perimenstrual, worrisome, postpartum or postmenopausal, excuse me. Other worrisome ones are heavy bleeding. I mean, if you have a patient who bleeds for 10 days and is saturating a pad, going through 5 or 6 pads a day, that's not normal. If you have a patient that's changing a pad every 1 hour for 3 or 4 hours, that is not normal. It does not necessarily mean there's a cancer, but it means there's something that's not right. It could be a fibroid, as I said. It could be an endometrial polyp. It could be a miscarriage if she's of childbearing age and not using any birth control. So those are the things that you should definitely go in and see your healthcare provider and talk to them about. Vaginal infections, yeast versus BV. Okay, Miss Rachel, can you put that other slide up for me? So, how do you know if you have yeast or bacterial vaginosis? How many of you you can just maybe raise your hands. How many of you have had a bacterial infection? How many of you know what bacterial vaginosis is? So,
no one on Facebook can see your hands if you raise them here.
That's okay. That's okay.
Pretty safe here.
So every woman should have a vaginal discharge. It is normal. It is your body washing itself out, cleaning itself. The normal vaginal discharge is usually clear to white. If you're not on a hormonal contraception, it can vary during the month. Sometimes it might be a little stickier and thicker than others. Sometimes it's a little smoother and creamier. It may have what I like to call a humany odor. So we all have our own pheromones that we produce, that we have our own body odor. But it shouldn't be foul or fishy smelling. When you wipe with the toilet paper, it should not be green or yellow. It may stain your panties yellow. That's just the interaction of air with the material from your normal vaginal secretions. So the types of discharge that you see on here, there's 3 infections that we can find under the microscope. The first one is bacterial vaginosis. The discharge is usually thin, homogeneous, it's white, gray, and it kind of sticks together. There's generally an odor, although not all the time, and it literally smells like fish. I mean, that's what my patients come in and tell me. I have this fishy odor. It is usually, the patient usually smells it more than anybody else around them, but everybody is concerned that everybody smells it. Again, you see the complaints from the patient: discharge, bags, odor. Sometimes it gets worse after intercourse, and sometimes it gets worse with a period. And the reason for that is the pH balance and the chemical reaction between those 2 things. Some women do have itching, some women do not. You can't see the cell there very well, but it's basically a skin cell that is just covered with bacteria. The first time I saw it, I thought of it, oh, it's like a skin cell with an afro all around it, because that's what it reminds me of. It's just got hair all over it. When you look under the microscope, that's what you're going to see. The second one on this slide is something called trichomonas. Trichomonas is a sexually transmitted infection. The discharge with it is usually yellow, green, frothy colored. It's excessive. The fishy smell may or may not be present. Patients will usually have itching and irritation, and sometimes come in complaining of dysuria, which is painful urination. So many times they'll come in and say, I think I have a urinary tract infection. Can't see this slide at all, and the slide is not that good anyway, because the only way to really see a trick, they are oval shaped. They have little tails called flagella on the end of them, and they basically use those little tails, those little flagella, to move around in the vaginal secretions. So if a trick is not moving, it's just sitting there and the tail is curled up next to its body, it may just look like a large white blood cell. So they're easily missed under the microscope in some patients. I think the statistics say in females, you can miss up to 30% of trick looking under the microscope. In men, that rate is even higher. I think it's somewhere in the neighborhood of 60 or 70% of the time you will miss trick in males. And that's simply because it lives in the urethra. And when men pee, they pee out the trick and what you would be looking for under the microscope. The last infection that we see commonly in the office is yeast infections. And it's probably the #1 visit that women make to the office. Usually the discharge is white and cottage cheesy. Sometimes it's not, sometimes it's smooth and creamy, but it usually is white. It's usually higher than, more than normal. There's generally not an odor, although I have had patients come in and tell me that they have a sweet smell when they have their yeast infections. And usually there's itching and burning and dysuria. Patients will notice pain when they urinate, simply because the skin around the vagina, the labia, is inflamed and red, and the urine is acidic and it hits that area and it burns. I can answer some questions about these later, but of the 2, I will tell you in my practice, although most patients come in for candidiasis infection, yeast infections, I see more bacterial vaginosis than I do anything else. In my opinion, it is the most common vaginal infection seen in the gynecologist's office. And that's just my personal opinion. I've never done a study on it, so please don't quote me on it. We talked a little bit about the human papillomavirus, but I wanted to go in just a little bit more detail. So the human papillomavirus is the HPV virus. It is not one virus. Depending upon what articles you read, there can be up to 120 different types of human papillomaviruses. Of that 120, there's probably in the neighborhood of about 25 or 30 that can affect the genital areas in both males and females. For females, of that number, there are 6 that can affect the cervix and roughly another 6 or 7 that can affect the vaginal walls and the vulva. And the only good thing I can say about HPV virus is that most of them, when they infect the cervix, are very slow growing. And by that, I mean, if you have an abnormal pap and your HPV is positive and you don't go back to your gynecologist for 20 or 30 years for follow-up, you're probably going to have cervical cancer. HPV virus is not cervical cancer. It's like when you tell somebody they have HIV, it does not mean they have AIDS. When you have human papillomavirus, you have the virus that can cause cervical cancer. In women under the age of 30, this virus will usually clear itself in 1 to 2 years without any treatment at all, which is why we started doing pap smears later in life, because when we did them on a 16 or a 17-year-old, we were subjecting them to colposcopies and sometimes freezing their cervix and sometimes doing surgery on their cervix to remove part of their cervix for low-grade mild changes that probably would have just gone away if we had just let them alone. But we didn't know that then. We know that now, so we put it off a little bit. The side note on the vaccine, I will mention that right now, is the HPV vaccine that is currently out is a 9-valent. So it treats 9 different HPV viruses, 2 that cause most of the cervical cancers, 2 that cause less frequent cervical cancers, but they're a little bit more aggressive. So they're more likely to become cancer left untreated down the road. And then the others just treat the viruses that can cause the vaginal warts and the warts on the vulva. Herpes. And also the HPV virus is probably the most common sexually transmitted infection that we see in the office. Although we don't hear a lot about it on TV, it is probably more common than chlamydia or gonorrhea. Herpes. There are 2 types of the herpes virus, herpes type 1 and herpes type 2. Most people associate type 1 with cold sores and type 2 with being sexually transmitted. The fact of the matter is you can get either virus on any part of your body. So you can get type 1 in the genital areas and you can get type 2 around the mouth. You can actually get herpes virus anywhere on your body. I had a patient years ago when I worked up in New York who had a herpes lesion that she got on her hip. She does not know how she got the virus there, but that was the only place she ever had a blister. So we like to think of type 2 as sexually transmitted, but as I said, either one can be anywhere on your body. You don't have to have vaginal intercourse to get type 2. You can have oral sex and get type 1 or type 2. Chlamydia, the next sexually transmitted infection, probably the second most common sexually transmitted infection we see in the office. Recommendations are for screening for women 25 and under every year, whether they've had a partner change or not, because that age group is the most infected with chlamydia infections. It comes from having multiple partners. You know, a lot of my young patients think of monogamy as I've been with my partner for 6 months and now I have a new partner. However, chlamydia can occur in older women. I have seen it in older women in long-term monogamous relationships, or they thought they were long-term monogamous relationships and they were not. I've also seen it in women who have stepped outside their marriage. So under 25, annual screening, irregardless of history. Over 25 based upon their risk factors, or if they just like to have it done. I have some patients that every time they come in for their annual, they get STD testing. Gonorrhea is another sexually transmitted infection. We don't see a lot of gonorrhea, at least not right now. Even when I worked at Planned Parenthood, we certainly saw more than I see in private practice or in the family planning area. We would see more gonorrhea, but it is not that common, and it tends to run in clusters. I don't know why, but if we have one patient in, I'm pretty much sure that I'm going to see another couple of patients. And it's not always from patients that, you know, live in a certain area. It's across the board. And the same thing with trichomonas. You know, trick is not very common, but when I see it, it seems to be that I see multiple patients within a month's time with trick. HIV, I'm sad to say that in private practice, it's not talked about as much as it is in family planning clinics or STD clinics. My recommendation for HIV screening for patients is if you've had a new partner, if you're going to have a new partner, if you think your partner has had another partner, have HIV testing. All the ones that we mentioned, you know, chlamydia, gonorrhea, and trichomonas, and syphilis down on the bottom are all curable. They all have an antibiotic that will treat them and cure them. HPV will generally go away on its own, even in older women. Herpes, there is no cure for herpes, but there are good treatment options. HIV, there are really good treatment options, but left undiagnosed can cause problems because without diagnosis, there's no treatment, and without treatment, it can progress to AIDS. Oops, hang on, my screen just went back all the way to the top. Let me scroll down here again. So we move from urinary tract infection, or from STD infections to urinary tract infections. The one article I read said 50 to 60% of women have at least one urinary tract infection in their life. Some are more prone to them than others. Some of it is related to hygiene. You know, remember your mother always teaching you wipe front to back, not back to front. And that's because the colon has a lovely bacteria called E. coli that is supposed to be around the colon. It's healthy for your colon. It is not healthy for your urethra or your bladder. And there are other bacteria that can cause urinary tract infections as well. They're much more common in postmenopausal women. Some of the thoughts on that are, you know, lack of estrogen, incontinence, if you don't have a panty liner or panties on, the urine sits and it can cause infection. A lot of postmenopausal women don't drink enough water, and they just, their bladder isn't flushed out, their kidneys aren't working as well. So those are some of the common causes for those types of things. Prevention and treatment, I just talked about one. You've got to drink water. Your kidneys are filtering out the toxins in your body. They filter them down the ureters into your bladder. If your bladder isn't sufficiently irritated by being full from the water, you're not going to go. And the bacteria just sits in the bladder, and it gives it opportunity to continue to grow. There's a bunch of antibiotics that are very good at treating urinary tract infections, macrobid and macrodantin, sulfa drugs like Bactrim and the generics. For patients with chronic infections, normally we would refer to a urologist for evaluation of other issues. And then a lot of times it's just taking a small dose of an antibiotic on a regular basis to prevent them. If those infections, especially in the postmenopausal women who get them with intercourse, sometimes you'll just take one pill if you have intercourse. If you don't have intercourse, you don't take the pill. Breast concerns come in the categories of breast pain, breast lumps, and nipple discharge. Breast pain can be normal, especially in younger women. If they're ovulating, they can have breast pain that occurs every month with ovulation. Ill-fitting, improper fitting bras can cause breast pain. Caffeine, any caffeinated drinks can cause breast pain. Alcohol can cause breast pain in some women. We always would want to address it. I would never tell you to not discuss it with your providers, but breast pain is usually very manageable and is not necessarily a sign of anything worrisome, although it can be. Breast lumps should always be evaluated. Breast lumps are like ectopic pregnancies to me. If you have a woman who's pregnant and you don't see anything in the uterus, it's an ectopic pregnancy until you prove it's not. In my mind, if somebody has a breast lump, it's cancer until I can prove it is not cancer, whether that's by mammogram or breast biopsy. It is something that you definitely should not ignore and talk to your healthcare provider about. It may be a benign fibroadenoma, which is just a benign fibrous mass that women get in the breast. It could be a cyst, but it also may be something more worrisome. And so it's not anything you ever want to ignore. And nipple discharge. Nipple discharge can be normal. Many patients who use Depo-Provera will get a milky discharge, sort of like breast milk. Not in the quantities that you would get from breastfeeding, but if they squeeze the nipple hard enough, they can get a little bit of milk out of the nipple. You work it up if it's normal. I tell my patients not to worry about it, just reduce nipple stimulation, consider stopping the Depo-Provera. But if it's green, if it's bloody, if it's yellow, again, that's not something I would tell you to ignore. Talk to your provider. You're probably going to need a mammogram or an ultrasound, depending upon your age. So once you rule it out as being pathological or cancerous, you can just kind of monitor it. And then we go into some perimenopausal and postmenopausal concerns. We talked a little bit about the irregular bleeding. In perimenopausal women, there's no reason they can't use a very low dose birth control pill. There are some, is one really good one on the market. You also can use IUDs, which will at least thin out the lining in a perimenopausal woman and hopefully make their bleeding either stop or be less irregular. The hot flashes, night sweats. I really wish I had a panacea to cure this, because it's probably the hardest thing in the postmenopausal women. Again, hormone replacement can certainly help. Estrogen and progestin both if you have a uterus. Estrogen only if you've had a hysterectomy. Layering, having a ceiling fan in the room, having the air conditioning set on 68, which will probably drive your husband out of the room. Looking for triggers. Some patients, if they have a glass of wine, will set them off in having hot flashes. Temperature controls. I mean, some of the things you don't have control over. For women who don't want to use any type of hormones, there are some other medications that can help. Sometimes vitamin E, B complex can be helpful. Gabapentin is a medication that's used for nerve pain. Taking it at night will sometimes help women with the night sweats that they can have at night. Taking it for hot flashes during the day is a little bit more difficult, because gabapentin makes you a little drowsy and can make it hard to function. But it is nice for the woman who says, I can get through the day, but I can't get through the night. The vaginal dryness we talked a little bit about already. The vaginal estrogen creams are one thing. There are also over-the-counter products. One of my favorite to recommend to my menopausal women is Riplens. Riplens basically is just mineral oil and vitamin E. It can be used every 3 days just to moisturize the vagina. It can cut down on bacterial vaginosis, although there's no studies on it, but I have had patients, postmenopausal patients, who have used it and used it successfully with that. There are also other things that you can do. You can buy coconut oil and put them in little tiny ice cube trays and freeze them. And you can put the ice cube into your vagina. It melts in about 15 minutes, but it does moisturize the vagina. Olive oil does not work as well because you can't freeze it. But certainly I have some women, if they just have dryness on the outside, on the labia, they can use coconut oil or olive oil. Vitamin E oil would be okay. You just have to be a little careful with it. Some of them have alcohol in it, which will burn if you do that. I talked a little bit about the decreased sex drive. It is a problem for a lot of postmenopausal women. And one of the biggest things that they say when I come in is, my husband thinks it's his fault. What can I do? you can tell your husband it's not his fault. It's just a side effect of, unfortunately for women, a change in their hormone levels. Again, I do have one provider who does do testosterone for their patients, and there are other medications. I'm not that familiar with them, so I will not address them, except to tell you that if you know a provider that provides those and you're interested in it, you certainly can have a conversation with them on it. And then the vaccines. I had to be careful here because, you know, I said in the beginning, a lot of women use their primary care providers, or their gynecologists rather, as their primary care providers. So most of the offices I have worked in offer some primary care vaccines. So I've listed the ones that we do, and we've talked about the HPV vaccine already. Recommendations for that is to actually start before your son or your daughter becomes sexually active. So the recommendation is between 11 and 12, although you can start as young as age 9. If you do that, it is 2 shots between 2 and 6 months apart. If they get that at that age, the studies have shown they have protection and don't need a 3rd shot. If they are 13 to 26, they need a series of 3 shots given over 6 months. One at month 1, 2 months later for the 2nd shot, and 4 months after that for the 3rd shot. The HPV vaccine has also been approved for about a year now for women over 46. I don't know if a lot of insurance companies are paying that at this point in time, but the reason that they changed that recommendation is because they were seeing an increase in women in their 40s getting cervical cancer from HPV virus. And they put it down to a lot of things. Many people in that age group were not vaccinated because it wasn't out. And then unfortunately, because of the high divorce rate, women get remarried or they don't get remarried, but they do enter additional sexual relationships, and their partners have had HPV and didn't know it. I should mention at this point that although young men can get the HPV vaccine, in men, there is no screening test for HPV virus, which is why it's so easily spread. If they don't get a wart, they don't know they have the virus. If they get a wart, they may never think, oh, I have a wart, I might have HPV virus, I might give it to my partner. It's just not a conversation that happens, although I certainly do believe that it should.
Pam, we have a question in the chat about this.
Sure.
And I think you've partially answered this. What is the recommendation for giving teenage girls the HPV shot? I did not receive the shot when I was a teen. Does this mean my daughter will not need to get it? Thanks in advance.
No, if a woman has had the HPV vaccine, it provides no protection for any of her children. I think that was the question. So she would need to your children would need to get the shot. Does that answer the question?
I think so. I think so.
Right.
Thank you. We also have some other questions too. So when you are ready.
Yep, I only have a couple more things to go through. Flu vaccine, I recommend it annually, beginning in October, going through January in the northern hemisphere. In the southern hemisphere, you start a little bit lower, a little bit earlier rather. Tdap, which is your tetanus and diphtheria vaccine, the recommendation is every 10 years. Zosters is for shingles. Definitely recommend it for patients over the age of 50, and I believe it's the 23 that's out now. That's on the chart that Rachel can pull up in a minute. And then pneumonia shot is recommended at 65, and it's recommended to repeat it every 5 years. Those are the common immunizations that a gynecologist's office might offer, with the exceptions of the zoster vaccine. And then lastly is just weight. Women are always worried about their weight. I have no magical answer for weight. I tell patients it's all about portion control, exercising, and the types of food that you eat. And the recommendations for weight loss is slow, steady weight loss. Don't use Jenny Craig, don't use all those others, because they're just, you go off that diet and you lose what you've gained everything back plus some, because you lose muscle mass and not fat. And that's it. I'm ready for questions.
Thank you so much, Pam. That was a lot of information, a lot of very good information. Appreciate you going through all of that. If you have, we're going to go through some questions that have come in through the chat. If you have any more questions on what Pam went through, please put them in the chat and we will do our best to answer them. One question that came in was, do you still need to go to the gynecologist after the age of 70?
I want to say yes, but you do need a breast exam. So if you have a primary care provider that you are comfortable doing your breast exams, you certainly can go probably every other year. Remember I said pap smear stop at 65. But if you haven't had a hysterectomy, you still have ovaries. My recommendation is a pelvic exam until you're feeling that you don't need one. And that is something that they call negotiation. So if you are uncomfortable coming every year and you're willing to come every other year, I think that's appropriate as well. Unless you're having problems, like I said, postmenopausal bleeding, vaginal discharge, dryness, that kind of thing.
Wonderful. Thank you. Thank you. All right. Somebody else mentioned the teacher's curse, UTI, hazard of the profession, I think. Have you seen that in your practice?
Not just in teachers. Anyone who is like a teacher who either can't get up and go to the bathroom. Nurses are another group that are notorious for not using the ladies' room as often as they can, because they get busy, whatever, they just can't get there. So yes, it is a problem for people who can't empty their bladder. What I usually will tell my patients is, my recommendation is at least 40 ounces of water a day. More if you're more active, less if you're less active. For me, I drink a bottle of water, 24 ounces on my way home from work, and I try to drink 20 ounces throughout the 8 hours that I am at work. That way I don't have to use the ladies' room quite so frequently at work, but I don't get up 6 times at night to go to the bathroom either.
And you still get some water in your system.
Yes.
And it's not just an issue for those of us who are younger. It's an issue for those when you get older and you don't get thirsty so much, right? Yep. And harder to get to the bathroom too. It's a struggle to find out what the solution for that is. All right, great. So another question that came in while you were talking about the birth control options was, is the sponge thing still a thing?
The sponge went off the market for a long time. I did hear it was back in Canada. I have not seen it in the United States.
Okay. Good to know. I think those are the questions. I've caught up on the questions so far. Are there any other questions that we have for Pam? I know she gave a lot of information tonight. And maybe, I don't know if there's anything on Facebook. Somebody made a comment. So much has changed. Definitely. Yeah.
And not just in the area of screening. Just as I said, in the exams itself, we don't do the exams as, I don't want to use the word thorough because that's not fair. They're not as detailed as they used to be, because we're trying to pinpoint what the patient really needs.
Right. And so maybe you don't do it as frequently, or it's really person by person, it sounds like.
Yep.
It's based on the individual. So that's wonderful. Are there any other questions or comments? I'm looking through the chat. If I missed your question in the chat, please type that in again.
If nobody has any questions right now, Rachel, can you pull up the other screen? I realized that I was talking about birth control. I forgot to talk about the oops. So do you have that?
All right, well, Pam's going over the last slide. If you have any other questions, please put them in the chat.
So we talked about birth control and preventing pregnancies, but things happen. The oops happens. If you're a condom user, your condom breaks. If you're a pill user, you forgot to take the pill. So what can you do? There are several options and they're all listed here. The most effective one is that copper IUD that we talked about. If it can be inserted within 5 days of the day that you had intercourse, almost 100% effective at preventing a pregnancy. The copper IUD works by causing inflammation inside the uterus. So inflammation means a lot of white blood cells. A lot of white blood cells means it attacks the eggs and the sperm, and they never meet. So there's no joyous reunion of the two of them, if you will. The next one is the Ella. Ella works by same principle. It affects the way that the egg and the sperm move so that they don't meet. It is almost 100% effective. It has to be taken within those same 5 days. If you're over 195 pounds, you'll see that it is a little less effective. You need a prescription for this one. And you cannot start the birth control pills for about a week after you have taken this, because the Ella interferes with the absorption of the birth control pills. The last one, the brand name is Plan B, but there are tons of emergency contraceptions available over the counter. Not as effective if you're over 65, and should be taken within the first 3 days. It is less effective at day 5. So it's best if you take it within the first 3 days of your oops. Always have an extra one on hand, especially if you're a condom user. Don't need a prescription for this. And age-wise, the last two, the pills, can be taken by anybody. The IUD can actually be used by anybody as long as their uterus is large enough to accommodate the IUD. Thanks, Miss Rachel.
All right, we have a few more questions. What normally should come out of you during your menses? What is abnormal?
The normal menstrual flow is usually a red, not a bright red, and yet not a dark brown red flow. It usually lasts somewhere between 3 to 5 days. Some women do pass clots. Some of them are small, dime, penny size. Some of them can be as large as a half a dollar. Those clots can be very crampy while you're passing them. Some things that you can do to help with cramping is ibuprofen before your period starts, or a leave. But the normal flow can be anywhere from a smooth reddish color to red with clumps and clots in it. The clots are usually darker in color and they can be stringy.
All right, thank you for that description. Do certain diseases like herpes only show up in places it came in contact with?
Yeah, herpes needs a way to get under the skin. So I use the example with my young people. If you have a drop of herpes on a Q-tip or in a pipelle, and you drop it on intact skin on your arm, you're not going to get herpes. If you have a cut or a scratch, the herpes virus can get into your skin and cause a reaction and end up with a herpes infection.
All right. Let me see if I can read this one. What is the difference between osteoporosis and osteopenia?
So osteopenia means that your bones are beginning to thin. They might be at risk for easy fracture. Osteoporosis means that the mass inside the cells is becoming hollow. Think of it like a honeycomb. Your bones should not be like a loose, large honeycomb. Osteoporosis is what they look like, and the risk for fracture is extremely high in women who have osteoporosis.
Okay. How common is it for a woman's medical history to be similar to her mother's? I've been asking my mother a lot of questions lately as I get older and notice changes in my body.
It depends on what things you're looking at. So I mentioned earlier that heavy bleeding can be caused by fibroids in the uterus. They're not hereditary, but they can run in families. So they're not genetically linked, but a lot of times if mom had fibroids, their daughters might have fibroids. If mom had really heavy periods, their kids might have heavy periods.
Okay. I hope I didn't miss any questions here. Anybody else have any questions? These are all really good questions.
If there are no more questions, there is one more slide.
Oh, one more slide. Okay, still have a...
Not really related to gynecology, but I wanted to put it out there because I think it's important for both men and women. So Rachel, do you have that last one? So in my office, we also do screening for hereditary cancers. And we do it for both men and women. So you can see on this little sheet of paper, we ask every annual patient who comes in, looking at first, second, or third degree relatives. If there's ever been an ovarian cancer, a breast cancer prior to the age 50, if that breast cancer, if a woman has had breast cancer in the right breast and it's treated, and then, you know, within a period of time, they get breast cancer in the other breast. If there's 3 or more family members on the same side of the family with breast or prostate cancer, if there's been a man in the family with breast cancer, which is extremely rare, pancreatic cancer, if there's Ashkenazi Jewish ancestry with breast or pancreatic cancer, colon cancer before the age of 50, endometrial cancer before the age of 50, or 3 or more relatives with rectal, uterine, stomach, or gastric, which could include the intestines as well, at any age. Those are reasons to think that it might be genetically linked. Most people are familiar with BRCA1 and BRCA2 genes, but all of those cancers that are listed there can be associated with an abnormal gene that can put you at an increased risk for those particular cancers. And there is testing that can be done. If you meet the national criteria, most insurance companies will pay for that testing. And that in our office, we offer it to both men and women. So if we have a young daughter who comes in and says, yeah, my dad's mom, my grandmother had breast cancer when she was 40, her dad can come in and be screened and tested, so she does not have to be tested.
So it's good to it's important to know your family history.
That's why once a year, the importance of going over the medical history cannot be stressed.
Excellent. Well, thank you very much. This was very helpful, a lot of information, and thank you all for your questions that you have sent in. I don't see any new questions coming in, but I really appreciate your time with us, Pam, and for all of those who have joined us this evening as well on Zoom and on Facebook. Thank you so much for being here. We try to do these about once a month, and our next session is going to be on June 22nd. It's going to be an information session for Narcotics Anonymous, and several members will share their experiences with us. And that's June 22nd at 6:30 p.m. We just hope you have a wonderful evening. Good night.
Thanks, everyone. I appreciate you all for coming.